Hi, I am Dr. Selvaraj, Professor of Surgery at Malacca Manipal Medical College, Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing their surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to listen these videos over and over again. In this episode, I am going to talk on yet another scrotal swelling. So I am going to follow the same format. Initially, I will be talking on the various causes of the scrotal swellings. Then I will present a classical clinical vignette and I will guide you how to arrive the most probable diagnosis. Then I will be talking about this diagnosis in detail, and then with the help of a mind map I will reinforce the knowledge. Then I will use a tabular column and I will show you by using this tabular column how to clinch the correct diagnosis. Then I will be showing a list of reference books. These books contain mainly the case scenarios, and those who want to solve these case scenarios, you can refer that. So what are the causes of scrotal swellings? You can broadly classify into acute painful swellings and chronic painless swellings. The acute painful swellings are torsion testis, acute epididymocarditis, torsion of testicular appendages. The chronic painless conditions are hydrocele, epididymal cyst, spermatocele, chronic epididymocarditis, testicular tumor, and varicocele. So here is our classical clinical vignette. Our patient is a 30 years old male patient presented with a swelling in the left side of the scrotum for the past 4 years. The swelling started in the lower part of the scrotum, and subsequently the swelling is slowly increasing in size and grown up to the root of the scrotum. The swelling disappears on lying down position and reappears on standing and on walking. The patient complains of dull aching pain in the left side of the scrotum for the past 6 months. The pain is more towards the evening when the swelling enlarges in size. There is no pain in the abdomen and there is no urinary complaints. So on examination, a mass of dilated vein feeling like a bag of worms is palpable on the left side of the scrotum along the left spermatic cord, extending from the upper pole of the testis up to the superficial inguinal ring. There is no expansile impulse on coughing, but instead there is a thrill is palpable. On lying down, the swelling completely disappears. On asking the patient to stand up, the dilated veins reappear. The left testicular volume is smaller than the right one. Abdominal examination is normal. So with this clinical finding, the patient is mainly presenting with a swelling in the left side of the scrotum that started in the lower part of the scrotum and extending upwards. He is also having dull aching pain more towards the evening time, and on examination you are able to palpate a mass of dilated vein feeling like a bag of worms in the upper part of the scrotum. There is no expansile impulse of the on coughing, but there is thrill is palpable. On lying down, the swelling disappears. On standing up, it reappears. The testicular volume also is smaller compared to the opposite side. So with all these findings, what is your diagnosis? The diagnosis is quite obvious. Merely by looking at these patients, you can come to a diagnosis with the bag of worms appearance. So what is your diagnosis? Yes, it is a case of varicocele, and that is what I am going to discuss in detail in this episode. So let us first talk about the anatomy of varicocele, how this pampiniform plexus forms. So the pampiniform plexus draining both the testis and epididymis, that makes the major bulk of the spermatic cord. So initially there will be around 15 to 20 veins in these pampiniform plexus. As they ascend upwards, the number is reduced to 12, and at the level of the superficial inguinal ring, there will be 4 veins. At the level of deep inguinal ring, it will be 2 in number, and when it enters the retroperitoneum, these 2 veins will join together and it forms a single testicular vein. The left testicular vein will drain into the left renal vein, whereas the right testicular vein will be draining into the inferior vena cava. So here you are seeing the external appearance this is the classical bag of worms appearance. So this you can see, and this is the internal appearance. You can see dilated vein inside after opening the internal spermatic fascia. So this is the anatomy. Initially at this level there will be 15 to 20 veins will be there. At the level of superficial inguinal ring it will be reduced into four veins. At the level of deep inguinal ring the number of veins will be 2. So when it enters the retroperitoneum, these two veins will join together and it forms a single testicular vein. On the left side, this left testicular vein will empty into the left renal vein, and this forms a right angle. It will end like a T here. Whereas the right testicular vein will end into the inferior vena cava obliquely. So what is varicocele? Varicocele is dilatation and tortuosity of the pampiniform plexus of the veins. It's seen commonly in men aged 15 to 30 years. It is very rare after 40 years. It occurs 15 to 20% of all males, whereas the incidence is 40% in case of infertile males. Normally, the diameter of these pampiniform plexus of veins is only 0.5 to 1.5 millimeter. If the diameter becomes more than 2 millimeter, then you have to suspect varicocele. So the varicocele is common on the left side because of the following reason. Because the left testicular vein is longer than the right testicular vein. The left testicular vein enters at a right angle to the left renal vein, and the left testicular vein will be compressed either by the left testicular artery or by a loaded sigmoid colon, or it may be compressed in between the aorta and superior mesenteric artery. This is called nutcracker syndrome. So what is the etiology of varicocele? Majority of them are idiopathic, and this is also known as primary, because here the main cause is because of the incompetency of the valves in these veins. So 98% of the varicocele is because of this idiopathic or primary cause. There are 2% because of secondary cause. Here there may be some other underlying pathology like pelvic or abdominal mass, especially the renal mass. The left renal cell carcinoma with tumor thrombus in the left renal vein is notorious to produce left-sided varicocele. The nutcracker syndrome, that is the compression of the left testicular vein between the superior mesenteric artery and aorta, can also cause varicocele. And retroperitoneal fibrosis and retroperitoneal adhesions can also cause the varicocele. So here you are seeing the classical bag of worms appearance. Here you are seeing it. The left testis will be hanging little lower than compared to the right testis. Here also you are seeing the same thing. This is the internal appearance of the pampiniform plexus of the veins, or the dilated veins called varicocele. So what are the clinical features? The patient may have dragging pain, particularly after prolonged standing during evening time. It can be differentiated from the omatocele by the feel of bag of worms. Many varicoceles are asymptomatic, and these are found only incidentally. It is more common on the left side for the reasons stated already. So infertility is more common in varicocele. Because of the varicocele, the temperature of the scrotum will increase, and this will impair the proper spermatogenesis. Bow sign, because if you held the varicocele between your thumb and fingers and ask the patient to bend forwards or bow, so the varicocele size will become decrease. So this is known as bow sign. On lying down, usually it gets reduced. On standing up, it will reappear. Long standing cases affected the side of the testis will be reduced in size. That side testis will be reduced in size. It will be softer also. So you can measure the actual size of the testis by using Prader orchidometer. And usually there won't be any expansile cough impulse, but if you carefully palpate, you can feel a thrill in these veins. So you can clinically grade the varicocele into 4 grades. Grade 1 is small varicocele, which is palpable only when the patient performs Valsalva maneuver. Grade 2 is moderate size. It is easily palpable varicocele without Valsalva's maneuver. Grade 3 is large varicocele visible through the scrotal skin. Grade 4 is very much dilated and tortuous veins. So what are the investigations you have to do in a varicocele case? It is a clinical diagnosis. However, you can confirm your diagnosis by doing a venous color Doppler of the scrotum and groin, both in standing and in Valsalva. After doing a Valsalva maneuver, you should do this color Doppler. Then you can do an ultrasound of the abdomen to rule out any kidney tumors. You must also do seminal analysis to rule out any oligospermia or azoospermia. So this is the color Doppler, venous color Doppler. You are seeing, you have to do over the scrotum. You have to place the transducer. You will be seeing the large dilated pampiniform plexus of the veins. Here you are seeing the large varicocele. Here also you are seeing many dilated pampiniform plexus veins. So what are the indications of surgery? The American Urological Society recommends treatment for varicocele in a male partner of a couple who are attempting to conceive and they are having all of the following. Number 1, the varicocele is palpable. The couple has documented infertility. The female has normal fertility or potentially correctable infertility. The male partner has one or more abnormal semen analysis result. The indication in adolescents are presence of significant testicular asymmetry. That means one side testicle is more than 20% size is diminished. Then that is an indication for surgery. And if the patient is having significant testicular pain and abnormal seminal analysis, these are all indications for surgery. So what is the treatment for varicocele? Asymptomatic varicocele, no need for any surgical intervention. You have to do only scrotal support and reassurance. If it is symptomatic, then you can excise the pampiniform plexus. More common is the inguinal approach. You have to ligate these veins and then you have to excise them. The testis can still have the venous drainage via the cremastic veins. So the surgery is known as varicocelectomy. There are the common approaches, or the most common is the inguinal approach. This is the easier and safe approach. Or you can go retroperitoneal abdominal approach, suprainguinal extraperitoneal, that is the Palamos operation. You can do either open Palamos operation or laparoscopic Palamo operation. For grade 4 varicocele, you have to do the scrotal approach. So here you are seeing the operative picture. This is the inguinal approach. You are seeing you have opened the internal spermatic fissure. This is the spermatic cord. You are seeing the dilated pampiniform plexus of vein. You have to separate these veins from the testicular artery and the vas deferens. Some are even using operating microscope so that you can ligate these veins one by one. But for that, this is known as micro dissection. You have to use a operating microscope so that the success rate will be higher. So here in these two pictures, you are seeing the laparoscopic approach. Here you are seeing this is the retroperitoneum. You are seeing the iliac vessels here, and here somewhere here you are seeing the testicular vein and testicular artery and vein. So you have to dissect it and you have to separate the testicular vein from you should not injure the testicular artery. You should not injure the lymphatics also. You have to ligate only the testicular vein. This is the laparoscopic Palamos operation. So there is another non-surgical procedure, or this procedure will be done by the interventional radiologists, where they are doing what is called percutaneous coil embolization. A steel coil or silicon balloon catheter is introduced into a vein below the groin through a nick in the skin. This coil or the catheter is passed under X-ray guidance. Tiny metal coils or other embolizing agents are introduced through this catheter. There is no need for any stitches. The patient can go back home in 24 hours. This coil embolization carries low complication, but it is less effective, and there is a higher recurrence rate compared to the operative intervention, 5 to 11% recurrence, and there is a danger of dislodging this coil, migrating this coil to the heart, and the patient can even go for sudden death. But fortunately, this complication is very rare. So this is the coil embolization technique. You have to put the catheter through the right superficial femoral vein. You have to go inside the thing, enter the, this is the common iliac vein. Then you have to go through the IVC. You have to cannulate through the left renal vein, go into the testicular vein, left testicular vein. Go. You have to do all these things under X-ray guidance. So you have to go below the in the testicular vein, and then you have to put a coil inside, so that this coil will block the supply, and the size of the varicocele will get reduced. So what are the complications of varicocele? So it may be hemorrhage, ultimately that will produce a scrotal hematoma, or infection that will result in pyocele, injury to the testicular artery, injury to the ilioinguinal nerve that will result in pain, or 5 to 10% cases the varicocele may recur. So this is the mind map. I have told you the importance of mind map several times, especially for the students. It will be very helpful for doing a very quick revision during your exam time. So coming to the varicocele, okay, what is the etiology? Primary is usually because of the incompetent valves in the vein. Secondary is because of some other underlying causes like abdominal or pelvic tumors, retroperitoneal fibrosis and adhesion, or compression between the aorta and superior mesenteric artery. So it is more common on the left side because the left testicular vein is longer. Left testicular vein enters at a right angle to the left renal vein. This left testicular vein may be compressed by the loaded sigmoid colon, the left testicular artery, or it will be compressed in between the aorta and superior mesenteric artery. There are 4 grades of this varicocele. Grade 1, palpable on valsalva maneuver. Grade 2, palpable without valsalva maneuver. Grade 3, visible through the scrotal scene. Grade 4, the veins are very much dilated and tortuous. Clinical features, majority of these varicocele are asymptomatic, or they may have a dragging pain after prolonged standing. It disappears on lying down and it reappears on standing up. Bag of worms feel is very characteristic. Bow sign will be positive, and then the infertility is because of increased temperature, because of the increased vasculature in the scrotum. Usually there won't be any cough impulse, but you can feel a thrill in the over the veins. So the affected side testis will be hypertrophy. That means it will be smaller in size. So coming to the investigation, it is a clinical diagnosis. However, you can confirm it by doing a venous color Doppler. You should do an ultrasound abdomen to rule out any kidney mass, and you must also do a seminal analysis to find out whether the patient is having oligospermia or azoospermia. The treatment is, the common treatment is groin varicocelectomy, or you can do it a retroperitoneal approach. This is called Palomos operation. This you can do either open or laparoscopic, or the non-operative coil embolization also you can try. This will be done by the interventional radiologist. So this is the algorithm. So I will be talking only about our case, that is the varicocele. Usually the swelling is you will be able to get above the swelling. You should be able to palpate the testis and epididymis separately, and the transelimination will be negative and it is non-tender. That is the characteristic feature of varicocele. So this is the tabular column. I have talked about this tabular column in all my previous videos also. So the important thing is this you can use as a ready reckoner to clinch the correct diagnosis. So the main thing is you have to compare and contrast your most probable diagnosis with all other diagnostic possibilities by doing what is called vertical reading of these columns. So this will be very useful to clinch the correct diagnosis. So here is the list of books which contains the clinical scenarios. Those who are interested, you can refer these books and you can solve these problems. So if you have any suggestions and feedback, kindly post it in the YouTube itself, or you can send me a mail to this following mail ID, the surgicaleeducator1954@gmail.com. So if you think that these videos are very useful to you, kindly share these videos with your friends. And if you have not subscribed for this channel, kindly subscribe to get notified regarding my new uploads. Thank you very much for watching my video cast. We will meet in yet another video. Until then, bye bye.